Welcome to everyone who's just joined us. We're just going to give people another 30 seconds. And we strongly encourage you to turn on your cameras to make this a little bit more interactive.
Even if you're in your pajamas, in bed, I did the first one of these in my hoodie. So making dinner, changing your baby, breastfeeding, any circumstances are welcome as long as you're comfortable to be on screen being recorded.
All right, I'd like to start by acknowledging the traditional owners of the land on which we meet across Australia and pay my respects to their elders past, present and emerging. And I want to extend my welcome to any Aboriginal or Torres Strait Islander people who are joining us tonight. Tonight it is my immense pleasure to introduce and welcome Dr. Dan Wilson in Victoria, who is presenting, we were saying, what shouldn't be a very niche part of medicine in transgender medicine. I'll let you take it away, Dan. I'm super excited to hear you speak.
Thanks, Marion. Hi, everyone. If you could turn your cameras on, I would really appreciate it. It does make things a little more interesting for me, but if you can't, I do understand, and do understand, particularly if you're burnt out at the end of the day, lying in bed listening to this with a bowl of ice cream in your lap. That's okay too. But my presentation tonight will be somewhat, it's developed to be engaging. So I will probably mention names. So a verbal response to any questions that I pose would be fantastic. And if you or if you don't want to speak, even just commenting in the chat would be fantastic, just to make this presentation a little more lively. So I'll share my presentation and we'll get started. Marianne, could I just confirm that is sharing in full screen view?
Yes, confirmed, Dan.
Great. I'm just going to bring up my chat box. I'll try my very best to keep an eye on it, but Marion, if you could monitor the chat, that would be fantastic. Thank you.
Will do.
So I've titled my talk Gender Affirming Care in the Bush. Went through a couple of different titles and this is what I've landed upon. Before I do start, I too would like to acknowledge the traditional owners of the land on which we're meeting. I'm normally coming from Wadawurrung country, but tonight I'm actually still at work. Do not ever follow in my footsteps. I'm on Wurrung country tonight, and I'd like to acknowledge the traditional owners. So tonight we're going to have a case-based exploration of gender affirming care. It seems that my slides have skipped potentially the first page, but that's okay. So this is the case that we'll consider RE. You're the new RG registrar at a new private practice in an MMM4 location. And if you're not MMM4, maybe think 5, maybe a 3, possibly even a 6 if you're really brave. So you're co-located and there's a counsellor on your premises that suggests they've got a possible new patient for you because the counsellor is aware of your interest and expertise with the start, or because you've come to this webinar this evening in gender affirming care. And your counsellor tells you a little bit about RE. They've given their consent to be discussed because they are looking for a new GP. RE is 24. They were assigned male at birth. They identify as female non-binary. They have a little bit of medical history for you to consider in that brief handover. They've got known anxiety and depression, and they're on desvenlafaxine 100 milligrams. And they've also been started on, quite recently, quetiapine, slow release 50 at night and 25 immediate release as required. Make of that what you will. And they do express they've got gender dysphoria. You know that they're taking the oral contraceptive pill called Levlin ED, and that was commenced at age 20 by another general practitioner. There's no surgical history and no developmental concerns. You get a little bit of social history from the counsellor, as any good counsellor will tell you, and RE lives with their mother and a sibling approximately 20 minutes away from your rural setting and an even more remote or isolated place. And they're smoking 5 cigarettes a day, and they're also smoking some marijuana each day as well. So for the initial consult, how will you proceed? And this is where things get a little interactive, and I will Those that have their cameras on will get the easier job of questions in this presentation at the start, and those without their cameras on will get the harder questions. So, Sally, you're my first victim. What would you like to cover in this very first session that potentially REs come to see you for the first visit? Just even one suggestion.
Hello. At first, it's just my lack of knowledge. So they're male at birth and identifying as female, and they're on the level in ed.
That's right.
Which is unfamiliar. I'd have to get a bit up on that.
Yeah.
And I definitely just want to get to know them, ask where they are in their journey, assess levels of supports amongst their family and friends and healthcare and who's been looking after them up until now. At the Katiapine.
So that all sounds like really good, safe medical approach, and you might even be preempting some of my presentation. So whilst you might feel a little hesitant and out of your depth, you're actually already starting to get into the in-depth detail of what an initial consult around gender-affirming care should entail. So I might go down my list of victims. I have Uila. What further information might you like to know from RE? Fantastic. Like to establish a good rapport.
So thank you very much. Probably I would like to establish a good rapport with my patient. And I would ask about medical history and even family history as well.
Okay, thank you.
To start off with.
Thank you. Thank you so much for participating. And Rebecca, you prepared for my next victim. Will you tell anything to RE at all? Will you say any particular statements, phrases, or words?
So I would probably ask them what they're looking for in a doctor. I think it's also good to establish that from them quite early in the piece as well. It's okay to find out what they expect and their expectations as well. And I'd also just touch base as what they need. Just because they've come to you from the counsellor looking for a new GP does not necessarily mean that they're visiting you for gender affirming or gender changer reasons. They could be there for other chronic conditions, but they are there because they've heard that you're willing to listen.
Thank you so much for saying that, Rebecca. And whilst this case understandably will go into the aspects of gender affirming care, it's really important for us to keep in mind, just because we've got someone who's gender diverse, not everything about them needs to be gender diverse care. They may just have stock standard chronic medical conditions that may need a lens of gender diversity applied to it. But thank you so much, Rebecca, for sharing, determining what the patient's agenda is and then mentioning what are they looking for in a doctor. So a few of us here tonight might acknowledge this is really outside my comfort zone, and actually saying that up front, that this is not an area of expertise of mine in terms of medical content, but I'm actually really willing to go on this journey with you, support you, and learn along the way, and hopefully we can achieve the goals you're trying to achieve. And despite everyone's hesitancies potentially to think I'm no expert in this area, you're already starting to touch on some of the guidelines already. So there are two big guidelines in this space that I've shared here on the screen now, and resources that I would encourage you to explore in your own time. Both of these are actually incredibly short PDF documents for guidelines around practice. The first is AusPath, the Australian Informed Consent Standards of Care for Gender Affirming Hormone Therapy. And then the second is from Equinox Clinic, a clinic in Melbourne, which is protocols for the initiation of hormone therapy for trans and gender diverse patients. Now, the scope of this talk will mostly focus on gender affirmation from a medical perspective. There's obviously so much more that goes beyond gender affirmation just in the medical sense, but just for the time constraints of this presentation, we will focus mostly on the medical affirmation as prescribers. What's helpful from those guidelines, and I think can give us a bit of a framework to think about medical affirmation, is to think of affirmation occurring in stages. So the first is stage one, which is really an introductory consult that you can use to guide the discussions. The second moves on to an initial medical review. They may merge and blend in the first consultation. We have a patient that's already on some form of hormone therapy, Levlin ED. So we may even touch on stage 3 slightly as well, figuring out a little around education about hormones and harm reduction. And then you see in this stages of gender affirmation care that hormone initiation, actually starting hormones, doesn't even occur until stage 4. And then finally, we'll touch on stage 5, which is monitoring and ongoing support. I'm just having some difficulties with my slides. Just seeing if I can get them to progress. Just going to stop sharing and try again, sorry. And try that once more. Is that now in full view?
It is, Dan, thank you.
Okay. So stage 1 is these guidelines are developed essentially with a larger multidisciplinary focus. So you'll see the terms such as introducing to the service. Obviously, in a more remote setting, we're probably looking to introduce to a practice. Goals really are to affirm that patient's gender identity, ensure that they feel safe in the practice and any other relevant cultural needs. Determine communication styles. So figuring out what language would like to be used. So some patients may feel uncomfortable with particular references to parts of the body, and a methodology of inquiry that remains open could be to ask someone who's gender diverse simply what terms they prefer to refer to biological parts of their body. So you might use an example such as, I'd like to talk to you about your genitals. Do you have a term that you'd like me to use when referring to your genitalia? Really non-confrontational. I haven't used the word penis or vagina in that sentence at all. I've used something that's already without gender, the word genitals. So trying to keep really neutral language. I think most people, before I even continue, really get a bit worried about stuffing up and saying the wrong thing. My God, I'm someone that would say I'm not an expert in gender affirming care, but absolutely have an interest and have rehearsed many sentences over the years. It still happens to me. Put your foot in it. You say sorry, you're on that person's side. We continue to learn. So don't be put off by doing gender affirming care because you feel like you don't have the right words yet. We've already mentioned determining the patient's gender, and also often relevant is to determine their sexuality and their sexual behaviours. It's not always relevant to someone's gender, but often that will form part of further care for that individual. And really what Rebecca's already touched on is really determine what the patient wants out of the rest of their care with regard to their gender care. That is, what do they want socially? What are they looking for medically? Do they wish to appear a certain way? And do they want any surgery to affirm their gender to remove that gender dysphoria that they experience? So we'll return back to RE. So RE's pronouns are she, her, and they, them. RE shares the following goals. They really want to be socially accepted as a woman, or at least a non-binary woman. They want to have a sense of belonging in their own body. They'd like to use hormonal therapy, as they've been trying to do for the last 4 years with Levlin. And as we might learn from the guidelines, it's probably not quite enough to achieve any form of substantive medical transition from assigned male at birth to socially female. They don't have any interest in surgical affirmation at this stage. They don't have dysphoria from their assigned male at birth genitals. And their chosen name is very important to them. You may hear some trans and gender diverse individuals refer to their assigned at birth name as a dead name. This is really important to RE to not be referred by their dead name. And the frustrating thing for practicality's sake is that RE is still going through the process of getting their documents changed for Medicare purposes. And in the practice software, they actually have to be registered as their assigned at birth name. And in brackets, we have their preferred name allocated. So it can be really frustrating for even a regular practitioner to still see that person's assigned birth name come up. Some other objectives that were unrelated to the gender are to specific, which is probably going to be improved by gender affirmation, is to improve their mental health and specifically to try and get off some of the agents that they're using. They really weren't happy with quetiapine at all. Become less dependent on recreational, over-the-counter and prescribed medications, and to be increasingly independent. RE acknowledge that they're incredibly dependent on their mother. Their mother essentially does everything for them, and RE doesn't drive. So we move on to stage 2. So stage 2 is that initial medical consult. So we obtain our complete medical history. What we're really looking for is any significant contraindications to using hormones in RE that we know was assigned male at birth, but we might be looking for contraindications to therapy that we think in our mind, if we're wanting to feminize, we're going to be needing estrogen. So what are some clear contraindications to estrogen? I won't put anyone on the spot for that, but the clear contraindications to estrogen are the exact same as those for menopause hormonal therapy and the same for oral contraceptives, okay? So uncontrolled or deranged liver disease, for example, would be one, or a known current history or previous history of venous thromboembolism, okay, might be a contraindication. Of course, these are slightly different for assigned male at birth because the presumption for MHT and oral contraceptives are that they are for assigned women at birth, but you can use those principles to guide your history taking. Consider any self-affirmation hormones that may be already used. You may not have many patients that come seeking this consultation to you, but in larger clinics, there's patients that are on all sorts of hormones that they've obtained online that they're using to self-treat. Some baseline investigations are really important. You really don't want to miss out on these. And this is why I like gender affirming care so much. It is holistic full person care, but you also really get that real like nerdy medical kick out of it. You actually do quite a lot of endocrinology stuff as well. So making sure you get a full blood count, biochemistry, LFTs, a bit of a hormone profile, because we're going to use some of these things to guide our care for transitioning from assigned male at birth to socially female, particularly some of the hormone profiles. But we do know that many of these hormones can alter our metabolic profile as well. So that's why we've got that baseline metabolic risk. And of course, always considering any age or assigned at birth sex appropriate screening. So for example, for RE, as RE gets older, RE has a prostate, and we may need to consider prostate screening that's relevant as well. And a big one not to miss that was covered up quite easily between myself and RE is to really determine what fertility goals that person in front of you might wish to retain. Because once you start transition, once you start medical therapy, you essentially need to detransition in order to obtain that level of fertility back once you've started. So it's really important to establish that early on, and it's okay to revisit it multiple times. So for RE, all normal baseline investigations. We have a free testosterone for RE that's 9.8, which is in the normal range for male sex from the laboratory. And the estradiol and progesterone levels were just marginally above what it would be acceptable for a male sex. And RE has no interest in fertility preservation after multiple discussions. And it's, I actually inquired specifically whether or not fertility preservation had been discussed back before starting on the pill, and unfortunately that discussion hadn't been had. So hopefully this is an impetus for us to, at least knowledge of those guidelines, for us to then ask those sorts of questions. If any questions are arising in people's minds, please pop them in the chat. I can either address them as I go, or we can save them to the end. So I'll keep us moving. Don't mind the funny pictures that are in these slides. These are like pre-made, and I was like, oh, that's a cute greyhound, but I think it's a greyhound. I want to get one myself. We get on to stage 3, which is counselling and education. So again, another visit. This is all quite a lot of work before starting hormones. Stage 3 is to re-explore those specific goals so that then we can target which specific hormone therapy we're going to provide for the patient in front of us. So are you wishing for particular facial features, voice changes, skin changes to really be culturally and socially accepted as for RE, a woman or a non-binary woman? This is also our opportunity to do a physical examination with a minimum of a BMI and blood pressure, again, because of that metabolic profile, and we'll be changing that with hormonal therapy. And really, a lot of my discussion is at number 3. What does the patient expect from hormone therapy? And I'm going to show you some resources around that I bring up every single time, because I forget the timelines of what I should be telling my patients what to expect after starting hormones. And we'll go on to a resource where you can do it together. And an opportunity to arrange any relevant referrals. I'm going to pick up on Marion here. So, for example, let's say that Ari's voice sounds like mine, reasonably deep in timbre. What would there be an appropriate referral that you might think of to help Ari with their any voice changes they'd like to consider?
I have no idea, Dan, but I am thinking I would maybe call one of my friendly ENT friends and just pose the question, because I don't know.
Yeah, so there's actually 2 options here. So when we think about voice, that's often distinct from the actual anatomy of the voice box. So RE does actually have quite a pronounced Adam's apple. And ENT, absolutely, all plastics absolutely can assist for an Adam's apple shave. You just really need to be resourceful, and it's jumping on Google to see trans affirming ENT, trans affirming plastic surgeon. That's going to be, and figuring out who in your local network could offer those services. Specifically for voice therapy, there are a number of listed speech pathologists on OzPath that you can actually refer to that have an interest in voice retraining. You might also think a little more creatively, and you might see people in town that are, this is a classic rural town thing, like voice coaches or like singing coaches. A lot of singing coaches actually have quite a lot of experience in dialect coaching, which will be able to help that individual retrain their voice to a pitch that they're seeking. So sometimes you've got to think a little bit outside the classic medical referral as well. So we'll get back to Ari. So Ari's goals are to soften their skin. They have very typically male skin that's been very testosteronized. They'd like to get some breast development. I was somewhat surprised with RE that they'd actually developed some level of breast development on Levlin, and I was somewhat impressed. But one of the goals was to develop breasts. Feminization of the voice was a significant goal. Decreased body hair. RE was affected by significantly coarse facial hair as well. Examination for RE, we have blood pressure and BMI there. Nothing particularly of note to be a contraindication to going any further. A little bit more for RE. We think about having a discussion around these things in particular, and that's what I covered in a consultation, are these 3 categories of hormonal management: the role of estrogen, the role of progesterone, the role of anti-androgens, and we'll touch on that very shortly. And for RE, thinking about a specialist endocrinology referral, but for me, that's absolutely has to be via telehealth. And how did I find people that will do that for me? It's Googling and calling some clinics. Again, a speech pathologist for RE, once again, started at OzPath, doing some Googling and finding someone that can do some voice retraining via telehealth, and getting it for RE, really important. They've got significant mental health concerns, staying with that current counsellor that they have. So now to the bit that everyone's waiting for, is getting started on the sexy stuff, which is the hormones. So we're now going to take a look at the resource that I use every single time for my patients. I'm going to stop sharing because I'll have to bring up the website and then reshare it. So I'm taking us to a website called TransHub. Has anyone been on TransHub before? Anyone heard of this website before? I'm going to take the dumbfound silence and shakes as an absolute no. I'm not sponsored by TransHub. This is a New South Wales-based organisation. This is gold for trans affirming care. All the guidelines are great and all, but you want something that's accessible and interactable in your practice. And this is exactly what we're after. So if you head to TransHub, we've got a bunch of different domains. social affirmation, medical affirmation, legal affirmation, like stuff that people are going to come to you with questions. So how do I change my birth certificate? How do I change my Medicare? So let's have a look at one of those as an example, legal affirmation. Look at this, broken down exactly what you're after. Change your name, change your gender marker, so M, F, or X on a passport, for example. Other identity documents, okay? There's a specific resource for under 18s. This talk is not touching on under 18s whatsoever, because that is a particular specialist area that I don't want to open cans of worms for the purposes of tonight. But let's look at the options for hormones. So we go through medical affirmation. You've got a bunch of options to start here with your patient. I do this in front of them. You can go to the Hormones 101 page, or if you're maybe a little more, I'd suggest checking out Hormones 101 or starting hormones on your own first. They're a really great introduction, but we're going to be pulling up feminizing hormones for RE. And I provide this resource to my patients. They'll come to you knowing 10 times more than you can learn in the 10, 15, 20-minute consultation you have. So it will tell you a little bit about estrogen in itself and some resources. Excuse me, some regimens that are options. It's all MHT, pills, patches, gels, injections, implants, whatever the person wants. Okay. Now, this is the gold. Counseling your person around what to expect from your estrogen. So, and it's right there in front of you. 1 to 3 months, you're going to start to get some of those early changes that not a lot of people think about. So the skin might change, the hair might change, the fat might move, but counseling around that your sexual function's absolutely going to change for Aria, who's been assigned male at birth, and talking around is sexual gratification something that's important for you? Yeah, Aria and I have established quite early on that using the word erection is appropriate and suitable for them. And that was something that we explored for a good half the consultation around what does that mean? Can RE still get any sexual pleasure in the absence of an erection? Those sorts of things. And then the second part of that table is more of those things that everyone's really looking for, is that nipple and breast growth and that real hair change that RE is looking for. We have a second category on the website here for you, which was that anti-androgen effect. So essentially my go-to is spironolactone in this category. And again, what to expect months 1 to 3 and those later changes as well. There's just a little precursory little look. And then finally, there's a section on progesterone. Progesterone is not a commonly used aspect of medical affirmation care. There's not a great deal of evidence to suggest that progesterone is required, but here you have a resource that you can call upon should you have patients that come to you seeking questions around the use of progesterone in their gender affirmation, but I won't get into that right now. So we'll head back to the slides. See how I go getting back on the right ones. How's that looking? We're up to stage 4 RE. Fantastic. So we'll get back to RE. So RE wants to explore as much as possible for their medical transition. So for estrogen therapy, I showed you that there were all the forms of MHT available: pills, patches, gels, implants. I don't have a trocar, the device that's used to insert an implant, but RE is really quite keen on exploring an implant as a means for their transition in the future. But we don't have that right now. So at this stage, we haven't gone with an implant, but they're really happy to take a pill. So going to TransHub, there is absolutely a resource that you can find within initiating of hormones, what dose to start. So I've just followed that guideline exactly, starting on estradiol valerate 2 milligrams daily and planning to increase every 3 months to achieve 2 things: clinical change and also biochemical change. And we'll briefly touch on that later in the presentation. Progesterone therapy, given that RE was essentially just on the pill, which we stopped, there's no real role to start progesterone at this stage because they haven't even trialed proper estrogen therapy yet. So think of progesterone as the add-on mini, maybe not much evidence bonuses when you've maximized your estrogen therapy. Yeah, it's like what's the point of giving this extra little thing with not much evidence? It's almost like your homeopathic medicine. It comes with probably no harm, and maybe there's a potential benefit at the end of the day. And we're also on advice from our telehealth specialist, who, by the way, reviewed my patient within 2 weeks, which was unheard of in the rural realms generally. So if you find someone that has an interest, hold on to them and don't let go, who suggested, given their particularly coarse hair growth, to consider the use of spironolactone, which I hadn't done in the initial consultation, conscious of not overwhelming the individual with so much information. I can just see a comment from Rebecca. Do we know where TransHub have sourced their guidelines for initiating therapy from? Yes, at the bottom of every single page on TransHub, there is a whole section with about maybe, I think they overdo it. There's usually about 10 links to resources from around the world. Unfortunately, there's no e-therapeutic guidelines, classic Australian ETG on gender affirming care. But really those guidelines from TransHub on the details of starting therapy are drawn from multiple different sources across the world. We'll keep moving. Now, in our minds, we've started hormone therapy. What's the final stage of the medical aspect of affirmation? So it's essentially all follow-up and support. So for me, I make quite an early follow-up. Guidelines don't suggest following up until 3 months. I like to follow up probably within 2 to 4 weeks after starting something substantial like this, just to make sure everything's going okay. Are they taking the medication? Are there any barriers? Was this cost effective? Are you able to access the medicine? But really the guidelines do look at absolutely following up every 3 months for the first year, and then afterwards at a minimum of 12 monthly. The purpose of that is to both monitor response in biochemical change, but also to look out for any side effects of therapy. So for example, if we were to think of a different case, for example, we think of someone's assigned female at birth and they're using testosterone, there are really a lot of effects of testosterone. They could end up with polycythemia, for example. So that's why we need to be doing an FBE for those patients. For RE, we need to be thinking about these biochemistry to consider. So we'll need to consider repeating a testosterone level because we want to suppress their testosterone as much as possible. We'll need to think about an estradiol to get it into a assigned at female range. We'll need to think about prolactin, as that's going to have a feedback mechanism from estrogen back on that hypogonadal axis. Estrogen and testosterone therapy will both affect the triglycerides, but notably it's more for the testosterone. And particularly in RE, we're going to have to monitor their potassium as well because they've been commenced on spironolactone. Just for interest's sake, if people aren't aware, when you're requesting hormonal profiles for anyone that's looking for medical transition, please note that on your medical pathology slip, because in your relevant state, wherever you are, they'll often get sent to a centre of excellence for further analysis. Because if they receive a request for estrogen and progesterone levels on someone that is assigned male at birth on their Medicare, they'll basically just write undetectable if it's under the male range. And that's not helpful because if you've tripled it from something insignificant to something, you then have an idea that your therapy is actually doing something to work. But if you don't put that on the form, you're going to end up pretty disappointed at the start of therapy because you're going to be seeing no biochemical change. Every 6 months, doing a blood pressure and looking at the person's BMI as well, then obviously changing that cardiovascular risk, and annually looking at the lipids and considering a fasting glucose, but that's not appropriate for every single patient, just to be considered. And of course, the whole time considering in RE's case, looking at their mental health, how can we further connect this person maybe with psychiatric services if required? But I have strong suspicions in this case of RE as we start to affirm RE's gender, this mental health. The mental health of RE is going to significantly improve. And in the guidelines, it's often referred to looking after the person holistically from a sexual health perspective as well. The data demonstrates that those that identify as trans or non-binary are at significantly higher risk of STIs and bloodborne viruses and are very high risk of not presenting to receive sexual health care. So whilst sexual health is not the same as gender affirming care, I want you to be aware that these individuals are often exposed in higher risk circumstances. So for example, having sex with men who have sex with men are in other high risk activities. So consider, in the case of RE, and this is something I discussed with RE, who their sexual partners were and determine the suitability for PrEP, as an example. So ongoing monitoring support of RE. And in classic rural fashion, RE has been lost to follow-up for now. So I've had 2 scheduled follow-up visits with RE, and we're struggling to get back in touch, which is a classic barrier within rural health. So we will keep, maybe I'll represent back at this virtual grand round with many more updates on RE, and I'm very optimistic that we will re-engage RE, because a little pro tip for those that you are thinking that are at risk of potentially this circumstance: don't give indefinite numbers of repeats on the hormones. And that's a good little tip for general prescribing, is that if you do need someone to come back, and this is a high risk prescribing endeavor, like the hormones aren't without side effects and risks, just do the number of repeats that you require and have that discussion up front. Don't be deceitful about it. Just say, look, I'm going to give you enough to get you to the next review, and then I expect to see you then. Unfortunately, in this case, I think in the back of my mind, I may have just given the maximum repeats. So I probably won't see RE for a few more months, but that's okay. This is just a return to the 5 stages of medical affirmation of someone's gender, going through those 5 stages from introduction, initial medical review, hormone education, hormone initiation, and then through to follow-up and support. And really, a lot of the real work gets done in stage 5. Stage 4 is the super exciting bit. Everyone's like, what do I prescribe? That's what Trans Hub's for. It's really 1 to 3. That's that big lead up that's super important. And then once you've got them on the hormones, it's about then exploring what next. This may not achieve what we're wanting to achieve for you. How can we now network and keep you safe and avoid high-risk behaviours because of your ongoing gender dysphoria? So a couple of things just to close. I know from the start of tonight's discussion, I saw a lot of hesitancy in everyone's eyes and hesitancy in the names of those that I can't even see, because this is not an area that this wasn't taught to me in medical school. Not one bit, not a slither of this was taught. So I suggest Trans Hub is the place to go, number 1. Please do have a look at either of OzPath or Equinox's guidelines, OzPath being the more Australia-wide recognised guideline, but those 2 guidelines are pretty much word for word very similar. It's just about which one you find prettier and easier to read, I think. I'd just like to close with a couple of things around tidbits. Be careful not to mispronounce that one, around the social transition. So I personally believe that this is, after caring for many people with gender dysphoria, that this is possibly one of the most important bits of someone's affirmation. As much as we all like to affirm someone's appearance to alleviate their gender dysphoria, that's not always going to achieve what that person's wanting. But getting the birth certificate to have their name, getting their passport to reflect their assigned gender marker as XMF, whatever's appropriate. But the number 1 is getting Medicare changed, because that is what the pathology requests will all say. That is what PBS scripts will all say. So until that Medicare is changed, that will be a constant reminder of that person's name. The second is some prescribing tips. So in the setting of adults, you can all prescribe estrogen without any help whatsoever. I mean, we're all going to ask for help, but you don't need anyone's permission to prescribe estrogen for someone who's wanting to feminize. That's not the same for testosterone. You can initiate it with a referral to either an endocrinologist or a sexual health physician. but there must be a referral at least. They don't have to have seen the partialist, as I often like to say, or the specialist, but you can initiate it as long as that referral has been made. None of this applies to adolescents. And that's where some of these special circumstances, which I'd just like to flag, put up a little reminder in your mind to stop and don't prescribe too early in these circumstances. Those individuals where you think there's a very high prevalence of significant mental health illness, where you're worried about the capacity to provide consent, or someone that has such incredibly bad depression, ongoing suicidality with poor insight into what's going on, that's a bit of a flag. This is the second one's really challenging. I'm saying put up a flag in those that might have neurodiversity that impacts their ability to provide adequate insight into their illness. This is hard because the prevalence of neurodiversity in the trans and gender diverse community is incredibly high, approximately 10 to 15 times higher than the general population. It is a tricky ground to walk. And absolutely anyone that is a child or an adolescent, stop, do not pass go, ask for specialist assistance before you do anything. Requires a lot more psychological evaluation prior. And the legal prescribing around this has recently, unfortunately, changed for the worse for children and adolescents. Previously, adolescents and children that you could deem as Gillick competent, so in most circumstances over the age of 14, or maybe in that realm 12 to 14, but could absolutely coordinate their life and make decisions, we could prescribe them the pill at the drop of a hat, someone who's Gillick competent. This year, a law was overturned that now, previously, it just required the consent of one caregiver or parent. It now requires the consent of both caregivers or parents, even if one of those parents is not in the picture at all. So there are loopholes and ways of facilities to get around that in demonstrating the utmost ability to do that. But for your relevance as rural generalists, we're unfortunately stuck referring those individuals to centres of excellence in quaternary centres, and hopefully looking out for those outreach clinics to be available as they are in each state. In Victoria, we're looking to get one up in Albury-Wodonga, but that doesn't help me out in Maryborough, geographically really far apart. I thought I'd leave a fair bit of time for questions, and I might take the slides down as an opportunity for people to ask questions. I know I barely scraped the surface. I didn't want to do anything too basic, but I was also conscious of not going too advanced. But I want people to feel like no question is stupid. This is not a topic that is taught about at medical school at all. So please feel free to ask any question you would like.
I have a question, Dan. Thank you for the presentation, by the way. That was really helpful. And like you said, this is stuff that I certainly wasn't taught in medical school, not even a tiny bit. So thank you for making it quite simple and easy to follow. So appreciate it. My question is, once you are getting into the territory of doing things that are non-reversible or sort of surgical, does that necessitate having a psychiatric review?
Simple answer is no. If you've deemed that the patient is an adult patient is experiencing gender dysphoria, and you believe that the goal of your overall gender affirmation plan is to alleviate that gender dysphoria, then surgical affirmation forms part of that plan and does not require any significant psychiatric review prior. Absolutely, in those guidelines, if you're unsure that the patient that's presenting to you fully understands that surgery is something that is permanent, because it's not necessarily permanent, all surgery can be reversed in some sense, but it's significant modification of someone's body. But if you're unsure, absolutely, I would suggest getting an assessment of capacity and insight prior. Had a couple of cases like that where you think, yes, I know you want to change your genitals, but couldn't really understand that that was a real undertaking, not only from cost, but the risks, consequences, outcomes of surgery. It's not an easy path to track, that's for sure. But generally speaking, patients come 20 times more informed than you are.
And there was that recent article of the Sydney gentleman where the psychiatrist had has some legal action taken against them. I think that sort of made me a little bit fearful of this area of medicine, to be honest. But yeah, I think there's some situations where it's quite tricky.
Dan, do you have much experience with the estrogen prescribing? At the end of the day, do you end up using doses that are similar to in menopause, or is it factors higher? Or
Sure. It's a really good question. You end up using pretty much maximum doses. So for menopause hormonal treatment, you're essentially trying to replace what was biologically given and already there. And in most cases, you're looking around, and the principle of MHT is lowest dose to alleviate most symptoms, not necessarily be Superman, Superwoman on top of the world. There is a kind of a different guiding principle for gender affirmation. You're essentially, in estrogen therapy, you're really working against what you're being given and fighting that. So you often do end up on maximal doses of therapy. And it can be frightening the first couple of times prescribing, maxing out oral estrogen, and then maybe throwing in another estrogen therapy as well in people that are incredibly typically masculinized, large muscle bulk, very hairy. You do get to quite high doses. But once I've maxed out one estrogen route, I am getting specialist support from an endocrinologist around what I'm doing further.
And when you say one route, so you would combine potentially a patch with a pill, and
in very uncommon circumstances, only guided by specialist advice. Yes, I've seen it before. Yeah. I might note that feminizing treatments, much longer, much harder. Masculinizing treatments, much easier, often end up with that classic socially passable appearance. Very, very difficult for feminizing, but that's just a generalization from personal experience and also what is published in the literature too. Marion, I'll let you guide if there's any questions.
Any other questions, guys, or is there anything else that you wanted to raise? No, brilliant. I think you covered it so well, Dan. Yeah, I just wanted to say thank you to everyone who joined us. It's really nice to see some new faces. We are part of the Rural Doctors Association of Australia's Doctors in Training group, and we meet every couple of months via Zoom, and you're all welcome to join us. Our next meeting is going to sort of coincide with the RMA conference, the ACRM RDAA conference, which is happening in Canberra. It would be great to see anyone of you guys who's planning to attend. Please make sure that you make yourself known and come and introduce yourself to us. But yeah, it's great to have you, and any questions or any suggestions for future topics for our next grand rounds in a couple of weeks, please do send us an email. Any questions or anything else before we wrap up?
I might take the opportunity just to encourage people that if they are looking to create welcoming spaces in their practices for trans and diverse patients, you might see something in the background of my room that's on the wall. My room's full of this kind of stuff. I'll see if I can take you all to the, again, not paid by this company, but I don't know if you can see it. It's Shine SA is the company, Shine South Australia. So that's a poster there. There's some up here as well. And I think I showed Marion before, there's some other stuff up there that's more general health as well. But if you head to Shine SA's website, they have a plethora of sexual health and diverse gender and sexuality posters. that do come with a small cost, but they're good quality, they're glossy, and they look fantastic in a frame. Thanks for your attention, everyone, tonight.
Thank you, Dan.